Okay, Brill. So yeah, thanks for introducing me and asking me to speak today. So yeah, as mentioned, I'm Ashley. I'm a bit of a perpetual rheumatology registrar in that I keep extending my training and straying away from becoming a consultant. But I'm also a clinical research fellow at Keele University, and I work with the Midlands Metabolic Bone Centre, which perhaps sounds a bit more fancy than it is, but we're based in Staffordshire, Stoke-on-Trent, and we're led by Professor Zoe Paskins, who's one of the international experts in osteoporosis. So I was invited to talk about my PhD and specifically a primary care survey that I've done as a component of it. But I've made a bit of an executive decision not to solely talk about my survey, which may be a little bit bland, and try and intersperse some learning with it as well, which hopefully you'll find helpful. I was told there'd be a kind of a broad spectrum of people on the call, so some of you may already know what I'm going to talk about. So apologies if some of it seems too simple for you, but if anyone has any questions or anything, you're happy to be interrupted. So as I mentioned, I'm funded by Versus Arthritis for my work at Keele. So I guess the first thing is to think about, well, why do I bother? Why does the Midlands Metabolic Bone Centre in Keele bother with osteoporosis? It's a condition that unfortunately doesn't seem to get as much attention as other conditions like diabetes or heart disease. But we know that 3.5 million people in the UK have got osteoporosis, and that 1 in 2 women and 1 in 5 men over the age of 50 will break a bone. There are 500,000 fragility fractures every year, and it costs the NHS in excess of £4.5 billion, which is over 2% of the entire budget. And at any one time, 4,000 beds are occupied by people with hip fractures. But it kind of doesn't have to be this way because we've got cheap and effective medications available, but we seem to have an issue with getting people started on those medications and indeed identifying who might benefit from them. And I guess that the most powerful thing to share is some patient stories. So I don't know if anyone's ever looked at this, but the Life with Osteoporosis produced by the Royal Osteoporosis Society. And here I've taken some quotes about how fractures affect people. So they cause pain, which we probably all experience in our practice and know about. But the things that are often forgotten are fractures can affect relationships, including sexual intimacy. They can result in social isolations. People become scared of going outside in case they fall and have another fracture. And importantly for the NHS, fractures make people unable to work, and that obviously has an impact broader than just on the economy, but also on personal quality of life in terms of finance. So I'm probably already speaking to the converted, but osteoporosis is a condition that we do need to take seriously to prevent fractures. So just an overview of the research I've been doing at Keele, really. So my PhD consisted of 3 kind of strands, if you will. So first, I did an evidence synthesis, a scoping review, to try and look at the barriers and enablers of osteoporosis care, specifically in primary care settings. And then I did a mixed method study, which was, for anyone interested, an explanatory sequential design, which means that you first collect quantitative data, then you collect qualitative data, and then you bring them together in a process of integration. So my quantitative data consisted of a national survey of primary care practitioners, whilst my qualitative consisted of interviews, again with a range of different primary care practitioners. And then we bring those two together in the hope of developing a suite of resources or a primary care toolkit for primary care clinicians to use in practice and hopefully aid them with the care of people with a risk of osteoporosis. And throughout this, it's been led by public involvement, really ensuring that we're trying to focus on the things that matter most to patients, as well as a large community of practice, which includes industry experts, secondary care specialists, primary care specialists, managerial aspects, etc. So the focus today is going to be on the national survey. So I always show this quote because, particularly when I'm speaking to a primary care audience, this is a message I had from a GP when asked to take part in my research. Because obviously, and it's a fair point, I'm a secondary care practitioner, so why am I interested in focusing on primary care? And often I know there's frustrations that exist between the two, but I don't want to be seen as someone who's trying to tell primary care what to do. But I think osteoporosis is a key example of one condition where we really could work together to make some simple improvements to really help people and make a difference. So, just a bit of background before I go on to the results of the survey. So it was open for around 2 months towards the end of last year. Indeed, some people in the call may or may not have completed it. It was quite a short time frame because obviously during a PhD you have to finish on time. So we were quite pleased that we managed to get 341 responses. And they came from a mixture of people. So 309 healthcare practitioners, so that included GPs, physiotherapists, pharmacists, etc. But also importantly, non-healthcare professionals, like practice managers, ICB leads, etc. Because really they play an important role in osteoporosis care as well. So I'm not going to focus too much on the ins and outs of this and really try and crack on with some of the results. So in terms of the baseline characteristics of respondents, most of them were white, so 75%, followed by Asian or Asian British ethnicity at 12.9%, with smaller involvement from other ethnic groups. The majority were female, over approximately 60%, with around 33% being male, the rest either giving no response or preferring not to share their sex. So in terms of, wide UK involvement, the vast majority of responses were from England, so over 85% or 290, but we did have some small representation from Wales, Scotland and Northern Ireland, which we were pleased about. But what we were really happy with was we managed to get at least one practitioner from 38 of the 42 integrated care systems from across England. So hopefully we've got a representative sample, because we know that clinical services vary vastly between different integrated care systems. And so we were glad to achieve that. Oops. So in terms of the job roles people played, the majority of respondents, nearly 200, were general practitioners, but we also had response from practice nurses, pharmacists, advanced nurse practitioners, and a whole group that we've just grouped as other for the purposes of this slide. But that included people like physiotherapists, first contact practitioners, physician associates, etc. In terms of the non-professional job roles, they include administrative staff, secretary, practice managers, PCN managers, clinical service managers, etc. The vast majority of the non-clinical health professional respondents were practice managers. So moving on to the survey itself now, which I hope will be a bit more interesting than the demographics really. So we developed a series of statements after we looked at the literature and spoke to our community of practice about really the core aspects of managing osteoporosis and the individual's thoughts about it. And I've just got the responses here split into green for agree with the statement and red for don't agree with the statement. And I guess the message from this slide, rather than going through each one individually, is that primary care practitioners are interested in osteoporosis. They think osteoporosis is important. But perhaps what they don't agree with so much is that they have a good understanding of osteoporosis. Around 70% agree that they did. And particular issue, again, less than 70% would agree that they worry about osteoporosis medicines and in particular the side effects. So we took some core aspects of osteoporosis care and asked the primary care practitioners if they were confident to perform those tasks. And you can see across these tasks there's a real split. So again, green would be agree with the statement, and red would be do not agree with the statement. And you can see that for every aspect of osteoporosis care here, approximately 30% did not feel confident in performing these tasks. But when we think about, well, what were the majority not confident in, we come out with two aspects really. So one was I'm confident in interpreting the numeric results of bone density scans, for example, T-scores. So I'm going to try and use the rest of the survey now to try and frame some educational discussion, I guess. So the first thing I'm going to speak about really is DEXA scan reports. So we know across the country there's a real issue with DEXA scans actually at the moment, particularly in terms of access. We know that some general practitioners or primary care practitioners are waiting greater than 12 months to obtain a DEXA scan, and that leaves a patient, in limbo really without a management decisions. And equally, we know that DEXA scan reports vary. I mean, this is taken from the Midlands Metabolic Bone Centre. We include a treatment recommendation for those that request DEXA scans. I know that doesn't happen across the country. We also suggest investigations, follow up, and give some additional advice. But I know that across the country, some primary care practitioners simply get the raw results of the T-scores, Z-scores, and absolute bone mineral density. So there is huge variation there. But one of the things that was reported as lacking confidence in was specifically around the interpretation of T-scores. So at the top here is what you may get when you get a DEXA scan back. Typically, or we would expect people to report the WHO diagnostic criteria, and I'll come on to that on the next slide actually. And then you would get results for the neck of femur, the total hip, as well as the spine, although spine isn't displayed there. And then what you get is the absolute bone mineral density in grams per centimeter squared. You get a T-score and you get a Z-score. And then hopefully you'll also get a FRAX score, and we'll speak more about FRAX a little bit later. So the T-score itself is probably the one that people are generally more familiar with. So the T-score is a standard deviation that compares the mean value of the patient with that of healthy adults that were at their peak bone mass, so around 30 years of age approximately. And that's why we can't consider T-scores in people that haven't yet attained their peak bone mass. So we can never use a T-score for anyone less than 30 years old, really. And then you've got a group between 30 and 50, where you can probably use T or Z scores as long as you're consistent, because they're broadly similar across those groups. But certainly beyond 50, we tend to focus on T scores. So, well, why do we focus on T scores? And really, it all comes down to the WHO diagnostic criteria for osteoporosis. So most of you probably know that bone mineral definition of osteoporosis is based purely on T-score, and a T-score of less than -2.5 is said to be equivalent to osteoporosis. But there's a real problem with basing osteoporosis purely on a T-score instead of a clinical diagnosis, and hopefully I can explain more about that in the next slide. But we know that, by the age of 75, 50% of the population will just have an osteoporosis range T-score. And so it's to be expected by that age that your bone mineral density would be in the osteoporosis range, and it's not necessarily pathological. Before I go on to speak about the problem with just focusing on T-scores, I'll just touch on Z-scores. So unlike T-scores, a Z-score compares bone density or mean bone density to that of someone the same age. And Z-score is particularly helpful when you're trying to identify secondary causes of osteoporosis. So usually if the Z-score is less than 2.0, then it would suggest that the patient has a secondary cause of osteoporosis. And in that case, you may need to dig a little bit harder and think about what secondary causes may be at play. But in terms of how we interpret Z-scores, so if the Z-score is less than -2, then we would say patient or person has low bone mineral density for their age. If it's between 0 and 2, we would say it's low for age. If it's above 0, then we would say it's above age. Hopefully that's clear, but please feel free to ask questions at the end. So I mentioned Z-scores less than -2 may suggest secondary causes of osteoporosis. So, well, what investigations might you want to do in primary care? So these are lifted from the National Osteoporosis Guideline Group guideline from 2021, which suggests that the first-line blood tests one may wish to consider in someone who you're suspecting a secondary cause. And I suspect you probably routinely do most of these: bone profile, vitamin D, celiac screen, myeloma screen. The ones that people often less think about are the endocrinology screen, specifically thinking about the thyroid or hormonal problems, testosterone particularly important in men. So why do I say not to focus on T-scores? Well, hopefully, the message is now getting out there that we need to move away from focusing on T-scores when thinking about osteoporosis, and instead we need to think about fracture risk. There are many reports of people not receiving treatment simply because their bone density scan didn't show osteoporosis or a T-score less than -2.5. But I argue that we should base treatment decisions on fracture risk and not purely on bone mineral density. Although bone mineral density is important, it's one of a myriad of risk factors for fracture. And we know that the majority of fractures actually occur in people who have osteopenic range BMD. We've also got quite strong evidence that osteoporosis medicines work in people with osteopenic BMD. And so we should need to move away from focusing purely on T-score and think about a more global concept of fracture risk. Just because someone doesn't have osteoporosis on their bone mineral density scan, it doesn't mean we shouldn't treat them. And indeed, you might see many specialists now using a clinical definition of osteoporosis rather than focusing on T-scores. The other, coming back to the statements here, the other one that the majority did not agree they were confident to do was to make recommendations about osteoporosis treatment break. So I'm going to try and spend a couple of minutes just talking about that now. So before I go on to that, I thought it might be helpful to just quickly give an overview of the medicines that are available for osteoporosis. Now, the ones on the left are the ones that in primary care I suspect you would use much more regularly. So they include the bisphosphonates, oral bisphosphonates being alendronate, risedronate, and abandronate. And you might notice I've purposely not called them alendronic acid because our patient group really responds negatively to the word acid. They associate acid with something from Hacienda in the 90s or something that would burn their throats, a bleach-like product, and it puts them off just calling them alendronic acid. So we try and encourage people to refer to them by the name, the suffix ate at the end, so alendronate, risedronate, for example. You may be familiar with raloxifene, but obviously that carries a venous thromboembolism stroke risk. Strontium ranelate, but that carries a cardiovascular risk. And the important medication often forgotten about that is helpful in osteoporosis, particularly in younger women, is hormone replacement therapy, of which primary care specialists are much more familiar with than I, so I won't talk about HRT in any detail at all. And then on the right is the drugs that we typically use in secondary care, although across the country I know that some primary care centres can prescribe denosumab with input from secondary care. But we've got again bisphosphonates, injectable ones this time being zeledronate or abandronate. We got denosumab, which is a 6-monthly subcutaneous injection that patients usually continue indefinitely. And that's because there's a risk when you suddenly stop denosumab of having multiple vertebral fractures. And then we've got our anabolic agents, teriparatide, which is a daily injection that would be given for 24 months. We've got a relatively new medication that's only become available in the last couple of years, which is romosozumab, and that's a monthly injection, or 2 injections, because you have to give 10 mils of volume, 10 mils of the drug. So patients have to do 2 injections once a month, and we give that for 12 months. And actually, since I made this slide, I think last month, NICE approved a new medication, another anabolic agent called abaloparatide. We haven't started using that in practice now, but over the next few months that will filter through, and you may be seeing patients coming back to primary care on abaloparatide. And the key message with all these osteoporosis drugs is we need to ensure people's calcium and vitamin D are adequate when they're taking them. And as a side note from that, it's important to also remember that calcium and vitamin D alone don't prevent fractures. So calcium and vitamin D are a supplement and not a treatment for osteoporosis or reducing fracture risk. I suspect in primary care, the most commonly prescribed drugs would be the oral bisphosphonates. And so I've tried to kind of put them on one page here, and I think the slides will be shared after if you think this is helpful. But I'll just focus on a couple of little bits if that's okay. So the first is around dosage and preparation. So important to remember that oral bisphosphonate is not just available in tablet form. Some people respond well to Bonosto, which is an effervescent tablet, and there's also an oral solution, particularly helpful if people struggle with swallowing tablets. What most people aren't aware, actually, is that although in routine practice we prescribe alendronate 70 milligrams once weekly for both women and men, actually it's not licensed in men. So just something to be aware of. Although it is routine practice, it's not actually licensed. One of the challenges that people experience with oral bisphosphonates comes around renal function. So bisphosphonates are one of those drugs where we don't focus on GFR, but we actually focus on creatinine clearance. And alendronate you can't give to people with a creatinine clearance of less than 35, but risedronate and abandronate allow a little bit more license, so you can go down to a creatinine clearance of less than 30 for those medications. And obviously beyond that, treatment becomes a bit more tricky, both in primary and secondary care, actually. And below 30, probably the only medication available to these patients is denosumab. People often get hung up about the side effects of oral bisphosphonates, and people tend to focus on the 2 very rare side effects, so atypical femoral fracture. So important to always advise patients, if they do get any thigh pain, to report that to a medical practitioner. If that happens, I advise that you get full length x-rays of the femur, both sides, because when present, atypical femoral fractures are often bilateral. The other is osteonecrosis of the jaw, which is a condition that affects healing of the jawbone if you have dental work done, for example, a tooth taken out. But the key thing to stress is that both these side effects are rare. They affect less than 1 in 1,000 patients, and they become more common the longer you've been on the treatment, which is why we consider treatment breaks, which was the purpose of this discussion here. The other message that patients often sometimes get confused with is what they can and can't do. So it's important that they take their bisphosphonate first thing in the morning, before any food, before any drink. Take it with a big glug of water. And the message is that they need to remain upright for at least 30 minutes. But upright doesn't have to be stood up. They can be sat down. Just what we don't want them to do is go back to bed and lie down. So treatment breaks then. So the guidance around this changed in 2021 with the published with the published NOG guidance. So now, for the vast majority of patients, we advise a 10-year treatment with oral bisphosphonates before considering a treatment pause. So for anyone over 70, anyone with a hip fracture, anyone with a vertebral fracture, or anyone taking long-term steroids, which would be the vast majority of the patients you'd be prescribing this for, we recommend 10 years treatment. And actually, in the National Osteoporosis Guideline, buried deep within it actually is this helpful flow chart. If you don't meet any of those criteria outlined in the bullet points on the left, then we would suggest 5 years treatment before a reassessment of fracture risk, a repeat bone density scan, to then advise whether to continue for a further 5 years or have a treatment pause again. We know that the NICE quality standards in osteoporosis are a little bit old now, but they were published in 2017, and they recommend that people with fragility fractures, people taking steroids, and people with a history of falls have an assessment of the fracture risk. So we asked primary care practitioners if this was routinely happening in their practice. So I've got the kind of results for each of those groups. But what you can see is that routinely fracture risk assessment is probably happening in less than a third of those groups, with a larger proportion of people being not so sure if it happens. But what we can see in the red there is again that a third of people with a history of fracture, falls, or taking steroids probably aren't having an assessment of their fracture risk. And there's many different reasons for that, which we may discuss. In terms of assessing fracture risk, just to touch on that, NICE guidelines recommend 2 different fracture risk assessment tools. So one is Q-Fracture on the left there, and one is FRAX. Both are freely available online. But we know there are frustrations with these from primary care colleagues, particularly that they're not built into clinical systems, which makes using them a bit tricky and time onerous. But hopefully we've got good news coming on that soon. So watch this space. Hopefully this will become a little bit easier to calculate within your own primary care systems. But I tend to use FRAX in my own clinical practice, and there's a couple of reasons for that. And the first is that FRAX can be used with or without a bone density scan. And equally, FRAX links quite nicely to the National Osteoporosis Guideline Group to give a treatment recommendation. Just when using FRAX, it catches me out all the time. Just always make sure you're on the UK version, because when you load FRAX, it often goes straight to the USA version, which is obviously not based on our own population. And when you calculate a fracture risk, this is what I mean by link to the NOG guideline. Many of you have probably seen this. It gives you your 10-year risk of major osteoporotic fracture, as well as hip fracture, but then it gives you the opportunity to view the NOG guideline recommendations. If you calculate it without bone density, you'll get 4 zones: lifestyle, measure BMD or get a DEXA, treat or consider specialist referral. And then in the middle there, you'll see there's an intervention threshold, and that gives clinicians a bit of license. So if the X is above the intervention threshold, then one could consider treatment without a bone density scan. And really that's for the group of patients where you think, DEXA scan might not be appropriate for them. It's a task to get them there. They may not be able to lie on the bed, etc. So the intervention threshold gives a bit of license to employ some clinical decision making. But as always with any calculation tool, it's only as good as the data that you put in it. And FRAX does have a few weaknesses. For example, it doesn't take account of whether people have had previous treatment for their osteoporosis. And importantly, it doesn't accumulate or dose the clinical risk factors. For example, we know that if you have a vertebral fracture, your chance of fracture is much higher in the future than if it was a wrist fracture, but FRAX takes no account of that. So the NOG group have kindly come up with some arithmetic adjustments you can make to fracts. And I've just put two of those here, which are probably the two that you would encounter most commonly. So if a patient has had two or more falls in the past year, you can inflate that fracture risk by 30%. The other it relates to type 2 diabetes. You've probably seen that within the FRAC score itself, it does ask if a patient has diabetes, but there it's specifically related to type 1 diabetes rather than type 2 diabetes. So for anyone who has type 2 diabetes, what we recommend is that you enter yes in the rheumatoid arthritis box, because rheumatoid arthritis and type 2 diabetes portray a similar risk for fracture. So in the survey as well, we asked primary care practitioners about medication reviews. So we found that around half of prescribing respondents would arrange a medication review after prescribing an osteoporosis medicine, whereas national guidance would suggest that that should occur in 100% of cases. But perhaps more interestingly, we found that when medication reviews are arranged, for around 3/4 of them, they were generic medication reviews rather than osteoporosis specific. And again, there are many reasons for that, not including, most obvious to me are time and staff availability. But if we know increasingly patients are on more and more drugs, so a generic medication review, you may only end up getting 30 seconds, 1 minute to think about the osteoporosis medicine, which probably isn't enough when there's some minutiae detail to think about. So we asked those people who conduct osteoporosis medication reviews, what they ask about in the medication reviews, and you can see that people responded really positively in terms of they always check adherence to osteoporosis medicines, ask about common side effects, ask how patients are taking their medicines, if they've had any more fractures. But what you can see towards the bottom is that people less commonly ask about back pain and height loss. And what we're thinking here is about vertebral fractures. And as a secondary care practitioner, the most important fractures to me are vertebral fractures, and I'll try and explain why. So we know that vertebral fractures are very common. 1/4 of women and men over the age of 50 will have a vertebral fracture, and once you get to the age of 80, half of women will have had a vertebral fracture. As briefly alluded to earlier, vertebral fractures are very predictive of future fracture. If you have a vertebral fracture, it's very likely you will go on to have another fracture. It portrays a 5-fold increase in the risk of further fracture. And we know of patients who were admitted with hip fractures, more than half of them had a prior vertebral fracture. So we've missed an opportunity to intervene at this stage with, as I've previously mentioned, cost and clinically effective medications. Vertebral fractures are very underdiagnosed. In fact, 30% of vertebral fractures never actually come to medical attention. And yet, the identification of vertebral fractures is important because it's almost an absolute indication for treatment or treatment switch. And there are many reasons for underdiagnosis. The first is that vertebral fractures often occur without fall. There's no trauma associated. Sometimes they don't cause pain. People don't consult with back pain because their first thought is that, well, it's musculoskeletal back pain. It may get better over the coming weeks and days. Traditionally, training has always been, don't arrange x-rays for mechanical sounding back pain, will simply show degenerative features. And sometimes that puts people off ordering x-rays for back pain in this group of patients, meaning that we, never find that vertebral fracture. And a real frustration of mine is, and I guess it's more important in primary care, where you can't actually see the images, is that radiology reports often don't use the word fracture. They'll say things like subtle height loss, end plate depression, 75% height loss instead of just using the word fracture, so we're all clear on what has happened. And vertebral fractures are burdensome. I'm not going to dwell on this, but this is some of the words that patients use to describe vertebral fracture. And you can see there's some emotive ones in there, unattractive, depressed, isolated, debilitated. They have a significant impact on patient lives. And as I mentioned, why do I care so much about vertebral fractures? Well, osteoporosis medicines are most effective for patients that have got vertebral fractures, and they're most effective at reducing future vertebral fractures. And indeed, our anabolic agents, there's been two big trials really, so don't focus too much on the detail, but one was teriparatide, an anabolic versus oral risedronate, and the other was romosozumab, an anabolic versus alendronate. And if you have romosozumab or teriparatide, you're significantly less likely to have future fracture when compared to oral bisphosphonates. And actually, we know that it's even more effective in patients who are treatment naive, which is why we're keen to see these patients early if we can. Obviously, that's becoming increasingly difficult with waiting lists and things across the country. So just going to focus on it and a few free text comments that I think will probably resonate with some of the audience. We asked primary care practitioners, well, what's the biggest block for you, or what's making things most difficult in osteoporosis management? And we came up with kind of 4 groups that I'll try and present to you now in the last few minutes. So one is that, osteoporosis is a challenging condition to manage, and whether you're a primary care practitioner or secondary care practitioner, you need specialist knowledge to manage osteoporosis. And there's an educational need out there, as reported by the primary care practitioners. And one thing that came out strongly here in the bottom right is that the clinical guidelines around osteoporosis, particularly for primary care practitioners, are inadequate. They're confusing, they contradict each other, they're not user-friendly. I mean, take what I would see as the gold standard guideline for osteoporosis, which would be the NOG guideline. It's an 82-page document. And, in a 10-minute consultation, it's not realistic for you to open that document and try and find the key nugget or sentence of information that you're looking for. The second is that obviously there's discontent with secondary care responsibilities. So secondary care take no ownership of this as an issue or problem. It's a source of unnecessary transfer of work to primary care all too frequently. Discharge letter will ask the GP to refer to bone health clinic, consider prescribing, or pass no comment. This should be addressed during inpatient care. And one way this may be addressed by secondary care is with fracture liaison services, but we know they're very patchy across the country. Only around 50% of the country has access to a fracture liaison service, and even when you do, there's great variation in the care that fracture liaison services provide. There's obviously a huge challenge in primary care, balancing competing priorities. And one of the issues that came out time and time again was the QOF indicators for osteoporosis, which are frankly inadequate. I mean, they're almost virtue signaling in that they ask people to keep records of osteoporosis, so simply a list of people with osteoporosis and fracture, but then compared to other conditions, they don't have that ongoing management section that suggests that people should do something about them. And indeed, I don't know if Chris Ellis is here. We were presenting to an all-parliamentary group earlier in the week, and this is one of the issues that he raised to the parliamentarians. And so hopefully going forward, there will be some changes around QOF, which may help incentivize this work, because as indicated by this GP, essentially it's unfunded work, and ultimately primary care practices are businesses that need to focus their resource in areas that make their business sustainable. There's an inadequate access to resources. I mean, I've already mentioned that there's long wait for the DEXA scans. One thing that's come up specifically from first contact practitioner physiotherapists is that they seem to be blocked from requesting DEXA scans for some reason unbeknown to me. So whilst they can request MRI scans or CT scans, radiology departments seem to put a block on DEXA scans. And I'm not quite sure what's happening from that. But my colleague Fiona Blackman, who's an FCP from the West Midlands, is looking into this. So hopefully some developments to come there. The one at the bottom is, an increasing issue for everyone. Access to dental care is problematic, but hopefully I can reassure you that to prescribe oral bisphosphonates, I don't think a dental review is required. I think you can just go ahead and start these patients on bisphosphonates. And actually, the Scottish Dental Guideline Group have a really helpful guideline on this. So just to quickly wrap things up then, so we asked how primary care practitioners think we could improve osteoporosis care. And there's a big long list here. I don't focus on the specifics. Some of these, it's difficult without policy to do anything about, more primary care staff, more time to see patients. But one of the top rated thing was improved education in the postgraduate arena around osteoporosis. So I've tried to put together a few slides of educational opportunities that I think might be helpful for anyone who's interested. So the Royal Osteoporosis Society, national charity for osteoporosis, has recently released bite-sized videos for primary care professionals, which were developed in collaboration with people working in primary care. And they're not just for GPs, they're for nurses, first contact practitioners, physiotherapists. And there's a whole host of different video modules on there. They're going through RCGP accreditation at the moment for CPD points, but they're freely accessible online. Obviously, I mentioned I'm a rheumatologist, and our society is the British Society of Rheumatology. So this is helpful not just for osteoporosis, but also for any rheumatological condition. The BSR have produced a whole set of standard responses to advice and guidance, and on there are many useful osteoporosis ones that may give you quick answers to questions you're asking. As I mentioned, the NOG guideline is probably the gold standard guideline for osteoporosis, but it's particularly inaccessible when you're in a rush. But there are some frequently asked questions on there, which I think are helpful and relate to specific questions. And there's also a 2-page summary, which includes most of the important information that you're most likely to encounter in primary care. So we've also just launched what we're calling the ERO Hub, which contains evidence-based resources for osteoporosis. And what we're trying to do here is just bring together nuggets of information that you can just click one button and access quickly. And that website is now live. Coming in April next year, which we're really excited about, is osteoporosis options. Now, what this is going to do for primary care is enable you to enter some quick details, and from that details, it will give you a personalized treatment recommendation, including what medicine, how long the patient should take the medicine for, when referral is indicated. It will generate referral text automatically for you. It will generate links for patients for medication counseling, information, generate risk plots, etc. And it will do that in an automated fashion. So hopefully in the clinic, that will be something that will be really helpful. So yeah, sorry, I've overrun slightly. I was meant to finish 5 minutes early, but yeah, open to any questions.
Thank you, Dr. Ashley. That was excellent presentation. Everybody's already raving about it on the chat. We have got a couple of questions if you wanted to kind of go through them quickly.
Yeah, I'll do my best.
You've talked about blood tests to rule out secondary causes. I find in my role in a back pain clinic where we have referrals in for vertebral fractures that GPs haven't done bloods to rule out secondary causes. Have you asked in your surveys why they don't? And just as in all the guidelines, including the quite recent, the GOV guidelines as well?
Yeah, so we didn't ask that question specifically in the surveys, but we have explored it in interviews. And there are a couple of points I would raise about this. So one is that, sometimes vertebral fractures are seen as a part of aging, people getting old, so people don't take them seriously. Two is, there's often a lack of knowledge about, well, which tests do I order? Some of these are expensive tests. How do I interpret them? You know, who needs them and who doesn't? And those, and obviously the other challenge is time pressures, people's time. Primary care staff have got to prioritize what they do and don't do. And accessing blood tests in primary care, it's more difficult than in secondary care. You can't just take them in the clinic like we do in the hospital. And so I think access is also an issue.
Brilliant, thank you. There's a question about FRAX score. FRAX does not routinely give treatment recommendations for hip risk, only for MOF. How do you get around this?
In terms of
I think it's mechanism of fracture, I think.
Yeah, I mean, so actually, the landscape on this is probably changing around hip fractures. So now, national guidelines says that first line treatment after a hip fracture is intravenous zoledronate. So hopefully, over the next year, as things filter through, you will actually realize that anyone with a hip fracture is actually already being treated with zoledronate. So hip fractures from that perspective should be uh, covered. But don't forget, hip fracture is a major osteoporotic fracture. It's, hip, vertebra, spine, shoulder, essentially.
Brilliant, thank you. There's a GP with specialist interest who
Mm.
would like to contact you for some discussions because they've done some work in their primary care area, if that's okay.
Yeah, of course, yeah, yeah.
And Andrea is asking, would we be able to access the link to the live website, which would be available next year, I think.
Yeah, yeah, I can. Oh, the one that's available next year.
I think.
So the one that's live at the moment is this ERO one, which is where we've
Euro.
tried to put these bite-sized clinical guidance. So yeah, I can share the link for that. But the osteoporosis options is coming from hopefully April time next year. But obviously, it's going to be a bit of a challenging rollout, and it will be freely available. That's the important thing. Often some of these systems like this you have to pay for, but this will be freely available. It's been developed by well, led by Zoe Paskins from a NIHR led research.
Brilliant. Thank you so much for a fantastic presentation.
Okay, Brill, thank you.